Hello, ladies and gentlemen. Welcome back to the lecture on the arrhythmias. So today we're going to talk about ventricular arrhythmias. Um, so when we continue about ventricular arrhythmia, we're going to talk about premature ventricular contraction, ventricular tachycardias, so premature ventricular contractions, ventricular tachys, and then also we're going to talk about ventricular fibrillation. So honestly speaking, um, this is more like understanding how to be able to detect an ECG finding on how does the premature ventricular contraction looks, what are some small little causes, and when is this abnormal, and when can you treat them. So that's the most important points about ventricular tachyarrhythmias. So let's continue and talk about premature ventricular contraction. Okay, so ladies and gentlemen, premature ventricular contraction is the similar thing as a premature atrial contraction. Of course, that happens in the atria, and this is happening in the ventricles. So it is actually basically a benign condition, and it usually happens between the QRS complexes, and it happens in a normal during the normal QRS complex rhythm. An abnormal ventricular contraction occurs, and that's known as premature ventricular contraction. Remember, ladies and gentlemen, when I say this is benign, it's only benign if there is one of this. But if it's greater than 3, then we have to treat it like a ventricular tachycardia. I'll talk about that a little more, but just remember that in mind. That premature ventricular contraction, you have to be very paying attention to it really much, because if it's more than 1, then we're dealing with a ventricular tachy possibly. All right, so before we start, what is it? I told you about it. It's just an abnormal impulse generation generating from an area of the ventricle that is probably due to, and it could be due to like some sort of electrolyte disturbances, or some sort of previous heart, for example, like increase in the size of the heart that can cause an abnormal generation of an impulse or some sort of scarring or anything. So in general, anything that can cause an abnormal contraction. Usually, sometimes in athletes, they say that premature ventricular contraction is okay. And when it especially goes away in the exercise, that's pretty much normal. So let's forget about the athletes right now. Let's have a look at on some ECG findings of premature ventricular contractions. If you look at this part, the premature ventricular contraction, it says occurs earlier than the next expected QRS. And that's exactly what's happening in here. It has happened, number 1 point, it happens in here before the next one right here. So another point is the morphology. Look at the QRS is so abnormally wide as well, right? And it's the T waves are opposite of to the QRS basically. So that's another good way to tell. Preceding P wave is absent. Usually you'll not be able to see. Look at this. This is a T wave. I don't see any P waves out here, so there's no P waves. Deflection of ST segment and T wave is opposite. As you can see, there's opposite QRS, and the T wave is opposite to that, the QRS, followed by a compensatory pause. This is exactly what's happening before the other one happens. Other normal QRS complex occurs, there's a pause between them. So that's about it. Now, we know that the QRS, of course, is going to be greater than 100 to 20 millisecond, and no preceding P wave, bizarre QRS morphology. That's the ECG findings, and you guys have to understand that part. PVCs may be benign, but are usually significant in the following situations. Of course, as I said, if they're greater than 3, they become abnormal, or multiform, varied in origin, different type. Like if it's arise with different morphology, it means it's from different origins, so you have to be able to detect that. I will show you the types of premature contraction, ventricular contraction, so you will be able to tell if it is varied forms or not, multiform or not. PVC is falling on the T wave of the previous beat. So let's say if we had a QRS, complex QRS, and then we had a T wave, but before the T wave, this falls on it, so it means that it's an abnormal PVC and it should be treated. It can precipitate ventricular tachycardia or ventricular fibrillation, and that's the most important thing. So this is basically a precursor for development of a ventricular tachys and ventricular fibrillation. But however, if it's alone, we don't bother with it, let it go. But if it's more than a couple, then we're gonna have to deal with it in like a aggressive manner. Okay, so let's talk about some types of PVC. If you look at in here, ladies and gentlemen, there are some types of PVC. Bigeminy means that the type of PVC that occurs after every other QRS complex. Couplet means that two of them occur at the same time between the normal QRS complex. And multifocal is when they are, for example, look at this QRS complex, and look at this QRS complex, greater than 120, different morphology. So this is what we have to what do we mean by varied form or multiform? Varied origin or multiform. Okay, so you have to be very careful about the multifocal ones. These are a little more serious, and it means that they are arising from different origins, so you have to be more careful about it. I hope you guys understand premature ventricular contraction. I cannot explain it more than this. There's not much about it that I can talk. It's benign, but remember, greater than 3, following on a T wave of the previous QRS, or it's multiform or varied in origin, you must treat them. And how do you treat them? Is, of course, you're going to treat them similarly like a ventricular tachycardia. So let's go ahead and now talk about ventricular tachycardia. Okay, so our friend ventricular tachycardia is basically three or more consecutive ectopic ventricular complexes. So as we say, if 3 or more of that premature PVCs can occur at one time, we'll treat it like that. So it's we'll treat it like VTAC. If you look at it, we'll talk about the ECG first before we move on. We can talk about wide QRS. Of course, this is QRS, and this is the wideness is greater than 120 milliseconds. And usually it's greater than 140, but anything greater than 120 is a wide QRS complex. Okay, so the rate is usually around 100, greater than 100, so it's 140 to 200 basically. Let's say, what is a ventricle flutter? Ventricle flutter. A ventricle flutter is basically if the rate is greater than 200 or between 250 to 350. If you guys remember, I talked about atrial fibrillation having 350 and above, atrial flutter 250 to 350. Similarly, ventricular flutter is the same thing. So ventricular flutter is basically the middle between ventricular tachy and ventricular fibrillation. That's what it is basically. It falls in the middle of these two. And that's why the rate is between 250 to 350. And if it's greater than 350, of course, we know that it could be fibrillation, right? And that's much more severe in consequences and complications. Sustained VTAC. When we talk about sustained VTAC, it means that it's lasting that greater than 30 seconds. So usually it lasts greater than 30 seconds. Non-sustained means lasting less than 30 seconds. When we talked about ECG characteristic, I just talked about QRS wideness only, but if you notice, another thing is that there is bizarre type QRSs. Like, it's pretty much very bizarre to say like that. The most important thing is AV dissociations, because what happens when there's a ventricular tachycardia, the AV node, when it sends its impulses, when the AV node, for example, sends impulses down to the ventricles are already undergoing another impulse formation from some sort of area like this area. So this impulse does not really bother this, and it's still generating abnormal ventricular contraction in the ventricles and causing a abnormal QRS complexes. So it doesn't really matter to it, and that's why the ventricles and the basically the atria and the ventricles are performing in different synchrony. They're not asynchronized. They're not performing at the same time, basically. So that's why the AV dissociation is another big hint in the QRS complex that can help you guys. And another time, what happens occasionally, this is another thing, if during a normal QRS complex, for example, a normal beat from AV node has been transferred. Like, for example, let's say if there's some sort of, for example, occasionally during ventricular tachycardia, supraventricular impulse, it means anything above the ventricle, an impulse that goes through the AV node, and it's by chance it's conducted. For example, let's say this is P, QRS, and then T wave. So let's say if the P wave, the impulse that's generated through AV node, it goes and it goes to the QRS, and when you have a ventricular tachycardia, this normal general impulse is going to get generated. However, this is going to show up in a sense of normal QRS complex, and I don't know, I'm not good at drawing this thing, but basically it will show like a normal pattern of QRS complex, and this is known as a ventricular capture beat, or sometimes it's referred to as fusion complexes. So it's basically between these ventriculars you will see a normal QRS formation formed again, and then again another impulse QRS complexes and abnormal QRS complexes. So just in quick refresher, because this kind of got a little bit more confused right now. I think some of you might have been confused on what I said. So basically, if there's a supraventricular, a supraventricular tachycardia, like an impulse from supraventricular above the ventricles gets generated to the ventricles, and while this is in impulse, while the ventricular tachycardia is going on, and then the abnormal ventriculars, let's say this is an abnormal ventricular tachycardia going on. Now during this time, a normal impulse can travel and it can cause a normal formation of, you see this part is known as a ventricular capture beat basically. So it somehow passed through, and during that time it went through the ventricles and caused a normal QRS complex. And this is what's known. Usually they look at that on ECG and they can detect they can say that, okay, that's a ventricular tachycardia by itself. All right, so I hope it's not confusing. I didn't confuse you guys enough, but just it's normal physiology. Anything can happen. Beats can pass through the AV node while the ventricle is in refractory period, or while the refractory period is ended, and it can cause a little bit of normal generation of a QRS complex. But however, the ventricle's in ventricular tachycardia at that time. Okay, what are some causes of ventricular tachycardia? Electrolyte disturbances can be caused. Drug overdoses, for example, TSAs, myocarditis, cardiomyopathies, digitalis toxicity, all these can be the reason for ventricular tachycardias. As we say, the VTAC is actually, I don't know if you mentioned this to you guys, VTAC is divided into monomorphic and polymorphic. An example of polymorphic would be torsade de Pontes. The monomorphic, from its basically name, you can tell identical complexes with uniform morphology. It's more common than polymorphic tachycardia. It typically results the same way from a reentry circuits that usually happens in the atria. The same thing can happen. An abnormal foci can be formed, and it might form a circuit around the ventricle to send back and forth the electrical impulse to the ventricles again and again and again and again. Some of the potential causes are chronic infarct scarring, acute MI, ischemia, cardiomyopathies, myocarditis, arrhythmogenic right ventricular dysplasia, idiopathic drugs, for example, cocaine, and electrolyte disturbances. Let's have a look at some of the polymorphic ventricular tachycardia. If you look at this here. You can see that the QRSs are of different morphology, amplitude, and polarity. So complexes with constantly changing morphology, amplitude, and polarity. It's also ventricular tachycardia, but it's the polymorphic type, right? So it's more frequently associated with hemodynamic instability due to faster rates. It's actually generates faster rates than the monomorphic one. So usually you will see a higher beats in this one, around 200 to 250. What are some potential causes? Acute myocardial infarction, severe or silent ischemia, and predisposing factors for QT prolongations. All right, so let's say, how do we treat ventricular tachycardias? Of course, in general, we have to know if somebody is hemodynamically stable or unstable. If somebody is hemodynamically unstable or compromised of hemodynamically, you have to treat them with electrical cardioversion or synchronized cardioversion, right? So we can also remember that. That's an important part. And if they have no hemodynamic compromise, you can treat them with electrical cardioversion, lidocaine, amiodarone, type A agents, procainamide, or quinidine. So these are the types of a treatment that you can actually use to treat ventricular tachycardia. And sustained ventricular tachycardia, anything greater than 30 seconds, is an emergency, so it requires immediate treatment. And that's very important for you guys to understand the treatment of ventricular tachycardia. And as I said, there's two types, monomorphic and polymorphic. So let's talk about one of the types of polymorphic, which is called the Torsades de Pontes. Torsades de Pontes, from its names, tells you that basically it's a variant of polymorphic attack that occurs in patients with baseline QT prolongation, which means twisting of the points. So if somebody is predisposed to having a prolonged QT, it could be due to the drugs, it could be due to, for example, electrolyte abnormalities or some idiopathic diseases like congenital long QT syndromes. They are more likely to be having an arrhythmia such as Torsades de Pontes. Usually the ventricular rate is around 150 to 300 beats per minute, and treatment is usually IV magnesium, temporary pacing, isoproterenol, and correcting the underlying cause of the prolonged QT. Electrical cardioversion if hemodynamic compromise is there. So yes, basically this is how Torsades de Pontes is going to be treated. Okay, so ladies and gentlemen, now we're going to go ahead and talk about the most important topic for today is ventricular fibrillation. I will let you guys have a look at the ventricular fibrillation ECG. Have you noticed? Look at this abnormal, chaotic, basically. It's a bizarre, disorganized, what we call is the QRS complexes that are happening in different morphologies and different amplitudes, and they're just like all over the place. So of course you're going to detect on ECG, you get the question of detecting ventricular fibrillation, and looking at ECG you're easily able to detect that this is ventricular fibrillation. Of course that's easy to detect it, but treating ventricular fibrillation is one of the most important topics. You have to understand how to do that, and usually a lot of the time the ECLS method is followed in order to treat ventricular fibrillation. And what I will do right now is basically I'll try to do my best to make sure that I can use an algorithm to be able to give you guys a little idea on how to follow up with the treatment for ventricular fibrillation. So let's go ahead, get an empty page and then start from there. So in general, we can talk about ventricular fibrillation, VFib, white complex tachycardias, white complex tachys, and either it's VTach or non-VTach. So what we're going to do is we're going to develop an algorithm for this and see what we can achieve from here. All right, so let's say we get an ECG. We get an ECG with, for example, a rapid ECG with a rapid, irregular, disorganized rhythm, and the patient is unstable. So of course you know that this is a possibility that this guy can have ventricular fibrillation, right? So what are we going to do? We're going to start some CPR. So we're going to start CPR, and we're going to minimize the interruption in here. Minimize interruption. So after we minimize interruption means do not try to stop the CPR. That's what I'm trying to say. Is after you do that, you kind of get to defibrillate this patient, right? You defibrillate him, and then you defibrillation either with a biphasic, 200 joules biphasic, or a 300 joules for monophasic. These are the type of defibrillator voltages you can use to treat these patients. Sure, if they come back, the rhythm is normal, so you're going to go ahead and continue CPR. If the rhythm comes back to normal, we're going to continue CPR. sorry, if we're going to continue CPR for 2 minutes after, right? And we're going to continue CPR if the pulse, and after that, the pulse is present. Basically, if the pulse is present, then we're going to go ahead and start to give them post-resuscitation care. Post-resuscitation care of whatever basically you have to do for this patient in the hospital settings. Let's say now we give this person with 200 joules or 300 joules from monophasic defibrillation, and the perfusion, or it's not basically coming back to the normal rhythms, right? So what we're going to do is we're going to continue CPR again, and we're going to check the rhythm. Is the rhythm a VTAC or VFib? If it's VTAC or VFib, we're going to go ahead, continue our CPR, and we're going to start on medications now. So medications will be the best now to go ahead with start. So we'll start with epinephrine, 1 milligram epi, 1 milligram IV, right? Every 3 to 5 minutes. However, after CPR, if you continue CPR, and you don't have a VTAC or VFib, you don't have this, then you treat the specific symptoms. Specific symptoms. So then you find out if it's not symptoms, then basically you just treat the symptoms. You don't have VTAC or VFib, so you don't have to worry about it. Now we said, let's say if the rhythm was VTAC or VFib, so of course we started CPR, right? We started CPR, and then we started medications, and then after the medications of IV, we're going to go ahead and we're going to start for up to 3 shocks. We're going to give continue after 3 shocks. We can basically start amiodarone. Now it's time for us to start amiodarone, and you can start amiodarone at 300 milligrams IV. You can start it at IV, and then shock again, and then after the shock you go ahead and give him 150 milligram again of IV amiodarone if he is not converted to normal rhythm, right? So the same pattern, and you continue CPR, drug, shock sequence until you return the perfusing rhythm, or it stops, or determination of to stop the ventricular fibrillation or ventricular tachycardia. So again, let's just go back up because we just came back a little bit too fast. So we say you take an ECG if you have a rapid, irregularly unstable patient. You have to go start on CPR. Number 1, you go ahead and defibrillate. If you defibrillate them with a 200 joules or 300 joules, if they come back for basically, if there's a return of the return potentially to the normal rhythm, if they return, if it was yes, and then you go ahead, continue for another 2 minutes of CPR, and check the pulse. If the pulse is there, then you go ahead and do a post-resuscitation care. But if the CPR, did not basically return to potentially perfusing rhythm, then you continue CPR. And then you want to check what is the rhythm at that time. Is the rhythm a VTAC or VFib? If it's no, then you go ahead and treat the specific symptoms. If it is yes, you continue CPR and you start on medication. Epinephrine, 1 milligram IV every 3 to 5 minutes. After 3 shocks, you start amiodarone. 300 milligram IV, you give him a shock, and then 150 milligram if not converted still. And then this is how you continue with CPR, shock, and drugs until the rhythm is the perfusing rhythm is present, or the fibrillation rhythm stops, the abnormal arrhythmia stops. So now let's have a look at this way. We can look at it in a different way now as well. If it's a white complex tachycardia and you see that the pulse, because we said that the ventricular fibrillation can be a white complex, ventricular tachycardias can be a white complex, as well as some supraventricular tachycardias with bundled branch can be white complexes. So let's say if we have a white complex tachycardia and the pulse, we're going to look at the pulse now. Is the pulse present? If it is not present, no, then we follow the same way that we do a treatment for ventricular fibrillation. That's how we kind of go ahead and we treat them this pathway. And the pathway, as you guys know, CPR, defibrillate, and continue to the bottom until you figure your way out. And if the pulse is present, however, yes, it's present, then what do? You want to check, is there low blood pressure, hypotension? Is there ischemia? Is there shock? Is there ischemia? Or is there a change in mental status? Is there any of these? If there is, if it's not, if no, then you go ahead, find out, is the patient relatively stable? Patient stability. You find the patient stability. Stable, patient's stable. Okay, so then, so basically, like after the low blood pressure and everything, you find out they don't have it, so of course, meaning that the patient is stable, right? So you go ahead and you find out the tachycardia. What is the reason for the tachycardia? Is the tachycardia physiologic? For example, is it physiologic, or is it with, for example, like with the tachycardia with bundle branch blocks or something like that? Then you go ahead and say either it's yes or no, right? So if it's physiologic, treat the underlying mechanism of the tachycardia. Treat the underlying cause. And if it's not, then you can use, if it's not, then consider adenosine. Then you can consider adenosine if regular. And you can use procaine antiarrhythmic drugs, for example, such as procainamide as well. Procainamide to control the, because it could be an accessory pathway that's causing this, and that's why it's more important to use antiarrhythmics to control the rhythm. All right, so let's say if this patient had a BP and for example low BP, shock, ischemia, or mental status, then what would have you done? Then of course you would have continued to give the patient a synchronized cardioversion, synchronized DC cardioversion, sounded like virgin, at 100 joules, starting at 100 joules. Okay. All right, so ladies and gentlemen, I know it seems a little bit confusing to you guys. It might seem confusing, but remember, this is just basically for you to understand it quickly on the way of how to be able to assess ventricular fibrillation and be able to diagnose it, treat the patients according to the ACLS method. But we're just going on an overall bigger picture of treating VFib as well as some ventricular white complex tachycardias that are VTEC or non-VTEC. Again, I'll just go ahead quickly and review this with you guys, so just you have an understanding of what's happened. Okay, so if we have any of these, for example, we go ahead and we check the pulse. If we have an ECG that's already abnormal, we're going to follow the pathway of this way. We go ahead and check the ventricular tachycardias. For example, is there any pulse present? If there's a pulse present, yes, we want to make sure, is the blood pressure okay? Is there any shock? Is there any ischemia? Is there any mental alter status? If there is yes, of course, go ahead and synchronize them, cardioversion at 100 joules. If this is not, so it means the patient is stable, relatively stable at this point. So you want to know, this is physiological tachycardia, right? For example, physiologic tachycardia with a bundle branch block. Tachycardia with a bundle branch blocks. If it is yes, then you treat the underlying cause, treat the specific tachycardia, for example, anything that it is. If it's not, then it means that you can treat them. It means there's something that's causing accessory pathways can be the reason for having these kind of tachycardias. Then procainamide can be used, or adenosine can be used to control these. I hope you guys understand a little bit of treatment for ventricular fibrillation, and thank you for listening. And please comment below if you have any other suggestion on making some videos that are useful for you guys, so I can try my best to make sure that I can make some videos that are useful for understanding and for helping you guys basically. And that's about it. Thank you very much, ladies and gentlemen, and have a great night. Take care.